I do want to introduce our panel, and certainly from an overview perspective, folks, it's not too often you can get the various perspectives that we have at this table all at the same table at the same time. So I welcome the kind of discussion that we will be able to generate here today. And starting from the end, in no particular order, no preferential treatment here, we have Karen Horon, who is the Senior Operating Officer, Pharmacy Services with Alberta Health Services. Certainly a good perspective to have, people that actually use the system that may not necessarily be in the physician environment. We have Ron Magnussen, which is a great pleasure, because we always talk about it's all about the patient. Well, folks, there's a patient, and there's a person that represents the patient. Very important part of what we do. So Ron is a patient advisor with Alberta Health Services, I guess, or with the actual governance model of the Alberta Netcare. Next to Ron, we have Dr. Sarah Muttitt, not a stranger to any of us here, and certainly she is currently in the role of Chief Medical Information Officer with Alberta Health Services. Next to Sarah, we have Dr. Alan Osford, who is so graciously agreed to join us today on short notice, because unfortunately Susan Anderson couldn't make it here today due to the things that we call a job. The people that actually pay her required her services today, so she had to go back. But we welcome Dr. Alan Osford, and certainly not from his previous role, which will be interesting to hear because he was sort of in the Sarah role previously. But we welcome Alan's perspective, certainly as a clinical professor as well as a currently active practicing physician. Which, of course, at the end of the day, that's where we would see a lot of the potential benefits, quality, and the whole reason why we do the things we do with the people in this room to try to improve patient care, patient safety, and quality. So I welcome our panel. Now, I have an unusual responsibility, and that is to give folks a very brief overview for those of you that aren't aware of what Alberta Netcare currently looks like or what it is. But certainly at a high level, I will say that for those of us that have been in the electronic health record world over the last number of years, we always look up to Netcare as, we used to call it a poster child, but I guess based on the amount of years now that we've seen Netcare develop and mature and evolve, it's probably more like a young adult these days. I welcome anybody that thinks that's not the case, but certainly that's the way we would see it, those of us that are in the electronic health record world and the journey that we've all undertaken over the last 15 years. Very briefly, folks, it's important for people in the room to realize the magnitude and the involvement that Netcare has had within their environment. Currently, from a user perspective, they have 44,000, nearly 50,000 active users, which is approximately 75% of what their target user base would be for Netcare. That in itself is a fantastic statistic, and I'm sure as we go through the panel and have some discussion, hopefully it'll be more than just a statistic. And when we look at the breakdown, you can see the types of people that are using the EHR in Alberta, and it is a broad range. I take specific note of the resident side. I'm not too sure many of us from the other jurisdictions can say we have residents using our current implementations of various electronic systems, let alone the electronic health record. And essentially, people in Alberta, or the way the model has been developed, is people that need the system for the purposes of delivering health care and or managing their own health can access Netcare. I don't know if there's anything, Sarah, beyond the general message of, I know it's not a free-for-all, you can't sign up like a driver's license, but it's a nice message to know that the accessibility of the electronic health record is there for those that may see the value in having access to it. More importantly, and certainly near and dear to my heart, would be what's the content? You know, it's like having access to a television station and you don't like any of the programs. I mean, you're not going to watch it. It's as simple as that. But when I got an update recently on what is contained in Alberta's EHR, it has come so far from the early days when we used to see what was going on with Edmonton and Capital Health with their client registry project, and the incremental addition of content and value to this system has been staggering, actually, in many respects. And as you can see from the slide, there is nothing within the system that is below a 90% content level at this point in time. Now, I'm sure that we'll have discussion about what additional content may be introduced over time, but certainly I think if nothing else, the Netcare example shows us how incrementally over time one can add extreme value to a system just by the constant momentum and maintaining the momentum of adding additional information, particularly on a province-wide basis, because these systems certainly would have value, but not to the same degree if they're not considered provincial or the information available provincially. I know, like many of our provinces, our people travel far and wide for healthcare services, and it's nice to know that the information not so much travels with them, but is available wherever they are within a particular jurisdiction. That's not unique to Alberta. That's something that most of us in the larger geographic thing is called provinces in this country are experiencing. The next slide gives an indication of when and how the enhancements occurred. And certainly this is, once again, a very good illustration of how there's not the big bang theory here. It is very incremental. And as we all know in healthcare, change is usually more acceptable using an incremental approach. And when you look at some of the dates and the timelines over the last 7 years here on this slide, it gives you an indication of not only the fact that there is incremental value being added to the network, but that there's actually been a plan in place that would allow that incremental value to be added over time. And that, once again, crucial to developing anything of a provincial nature. The most interesting slide I found when I was doing my overview from our friends in Alberta was this one. And as you can see from the slide, it clearly illustrates that as content is increased, as the value or the perceived value of the resource is increased, so does the level of adoption. So does the level of participation from the healthcare system. Once again, there's not a big bang theory. You don't go live with an EHR and all of a sudden your 50 or 60,000 providers in Alberta have access to the system. It takes time, but over time you can see that the adoption certainly, I'm not saying there's a cause and effect relationship here. I'm sure there's researchers that could tell me one way or the other, but there certainly seems to be an obvious correlation between the amount of people that are using the system, that have signed up to use it, as the content of the Alberta Netcare system has increased. So that's my little 2 minutes. I'm usually doing the Newfoundland Labrador electronic health record. That was interesting, doing somebody else's. And of course, usually I tell people about all the pitfalls as well of the system, as well as all the benefits. But I will leave it to these fine people at this table now to take us further down the road to what has been an arduous, I'm sure, controversial at times, and I'm sure wrought with political challenges as well throughout the number of years that Netcare has been under development. But given the panel and where we sit here, I really feel compelled to ask our patient representative, our patient advisor, Ryan Magnussen, to tell the room, because we all know where, I'm sure where Sarah and Alan and Karen where their perspectives are coming from, but from the perspective of the patient, I think it'd be really interesting to know, what does Netcare or similar systems to it mean to the patient? So from the patient's point of view, Ryan, I put you on the spot. I ask you, tell us your story with regards to Netcare.
Good morning, everybody. Just to start, prior to being disabled in 2004, I was a bank manager, and then after that, president and CEO of a company that was one of the fastest growing companies in Canada in 2000. I've been disabled now since 2004. Currently, I sit on the e-referral steering committee, the Calgary Zone Quality Council, and I've been involved in stakeholder groups for the IMIT strategy and the Path to Care strategy. Currently, I have approximately 13 different diagnosed diseases and 13 different medications, so I've had a very complicated medical history. Mainly, it's been severe chronic pain for the last 26 years. Avoided going to doctors and stuff, but the main three items would be ankylosing spondylitis, completely fused my spine and ribs to the progression of a 70 to 80-year-old, severe Crohn's disease from taking medication, severe osteoporosis, and like I said, many other conditions. The spine had fused except for the top two vertebrae, and Also, I've been a research patient taking biologics for 12 years. For the Crohn's, started off with one that worked, one I had an allergic reaction to, and now I've been on Humira for 12 years. And it helped the Crohn's, but seemed to exacerbate the ankylosing spondylitis fusing the spine. I've been a patient at the Calgary Chronic Pain Center from 2004 to 2010, and so I could study and realize how to live with chronic pain and, of course, taking narcotic medications. On October 17th, 2011, I was supposed to take my mom's car in for winter tires. I had a terrible night, usual pain, bad GERD at the time. To help me try and get back to sleep, I have medication I take at 4 a.m. every day for the last 15 years. I had smoked some marijuana, which of course I'm legal for, thanks to Health Canada. And that helps me get back to sleep. My wife got up at 5:30 and was showering to go to work and stuff and had not shut off the alarm. Apparently, when it went off, I got up too quickly, my blood pressure dropped, and I passed out. I hit the floor with my forehead. It was a third such episode I'd had that year, so that sort of plays into this. And so the next thing I recall was waking up and hearing this voice at the door saying, "Oh, somebody's been smoking up in here." And my wife and son informed them that it was legal and not to be concerned about it. And this instantly seemed to turn one of the paramedics angry, I guess, and he became quite rude with my family, insisted this is what had caused the fall, and started to like to say there's no way he could be seriously injured. First thing I remember was hearing that, and I tried to get up, and as I rolled my shoulder, my head didn't move, and I felt this really weird click. Tried again, it didn't work. And the next thing I know, I have a guy standing over me talking to me. And I'm like, "Who are you and why are you here?" And he's like, "How do you feel?" I said, no, why are you here? He said, "You suffered a fall." And I was starting to just come to it this time, right? For some reason, I know they deal with much more worse things than marijuana, but like I said, it seemed to set a tone for the way the treatment was going to go. The one paramedic was doing his assessment. They got me set up a bit on pillows doing his assessment. The fire department, of course, showed up at that time. And the other paramedic, assuming that there was no serious injury, sent them away because he didn't need any help. As they continued their assessment, they started to realize that I couldn't move. And so the discussion took place beside the bed, like, how are we going to get him out of here on the stretcher? I live in a bungalow, but there's 3 steps down at the front door, 3 steps at the garage, so for those two to carry me on the stretcher was going to be some difficulty. And so they said, "Well, is there any possibility you can get up and walk out?" And I said, I can't, no. And then they said, "Well, how about if we help you? You know, if we help lift you up and walk out?" I said, "I can try, I really don't know." So we managed to get me up, and they were on both shoulders, sort of helping me down the hallway, and I was holding my head like this, and I kept telling them, I keep feeling this slipping and a cracking noise, but it still wasn't registering to them. At this time, on my narcotics level, I was up to 45 milligrams of hydromorphcontin every 8 hours, so equivalent of like 27 Percocet every 8 hours. But I kept telling them I'm at a 9-10 pain, right? Somebody on that type of medication should not be at a 9-10 pain. I have osteoporosis, I have this, you know, like I said, for some reason, it just wasn't cluing in. So they got me out onto the stretcher in the garage, got me in the ambulance. And as we started to drive, we hit the first curb. And I mean, that hurt like nothing on earth. And then as we went to the next 2 corners, they had to stop. So it was stop and go around the corner. And those hurt really bad. But the third corner was a green light, and they went through it at the speed that they would. Well, the pressure on my neck was just insane, and I made them stop. I said, "You guys, like, you have to stop. I cannot tolerate the pain anymore. You have to either give me a collar, a towel, something around my neck so I can at least get to the hospital." They'd also been given, you know, my in case of emergency card, which listed all my medications, disease, and stuff. I had, the impact area on my forehead was 3 to 5 inches of rug burn, and I never once complained of head pain, only neck pain at a 10 level. So so we get to the hospital, and the first thing that they noted there was I had a modified C collar on. Later in an investigation, the paramedics claimed that they put the collar on at the hospital and that they hadn't done that. Now you can't imagine a nurse just automatically putting on a collar somebody coming in. after time, I was sent for an x-ray and CT scan of my head. And then what happened next was sort of like on TV. They're bringing me back to the emergency room. The doctor was on the phone. All of a sudden, it's hangs up, jumping over the counter. He's got a broken neck, don't move him. And I'm like, oh, okay, great. And they started taping towels around my head and all that. Of course, I broke C2 through the base of the axis and the dorsal part of C1, so I basically cleaned my head right off. The only thing I say that allowed me to survive and not be paralyzed was the fact that the rest of the spine was fused below, so it held C2, C3 in place, C1 to the head. Everyone at the hospital, of course, got me set there. They'd taken me to the hospital where they don't treat spine injuries, so I had to be transferred to another hospital. When the paramedics showed up there, they wouldn't touch me until they had liability letters signed off by the doctor at Rocky View and at the receiving hospital. So, you know, later on I start to realize just how lucky am I, right? Like, I really shouldn't have survived that fall. And the walk out of the house as well. That was probably even more amazing than the fall, to be able to walk out in that. So what I'd like to say to people is, you know, put yourself in my shoes and how would you feel at that point, right? Now, imagine if those paramedics had access to my complete medical records instead of having to guess and assume what had happened. They would have known everything about my conditions, about my medications, and that error would not have happened. So I decided in the hospital, waiting for my surgery, that I was lucky to be alive, and for the past 6 years, and going up on, of course, those strong narcotics, I didn't participate in life very much, but I decided to dedicate whatever time I had left in life number 2 to improving quality and safety for patients, and that's when I became a patient advisor.
Thank you, Ron. Certainly an extreme example, but folks, there's so many extreme examples out there in our healthcare system and with our population in this country. So it's certainly it's eye-opening to see what improvements we can bring to the table to make the situation better, to say the least. Actually, and from another perspective, I'd like to ask Karen, because Karen, you work as a pharmacist within the hospital environment. Is that correct?
Yes.
What does it mean to you to have Netcare? I mean, I know that we all have HISs in our hospitals and they all have different modules and functionality. What does it mean when you bring a provincial system into the picture, and how does that work within your environment?
It's absolutely fabulous, and for those of us in healthcare in Alberta that remember when we didn't have Netcare, and I do, it's so much better. Now when a patient is admitted to the hospital, pharmacists go into the event history in Netcare, and we are able to see previous exposures to emerge departments, previous admissions. There's emerge department records that have been scanned into the system. There's discharge summary information available. There's lab work, microbiology. All of the labs are in there. Diagnostic imaging and radiology reports are there. And so you get a really good picture of what's been happening to the client or the patient prior to them coming into the hospital. Then you go into the medication history, and there's an opportunity to look back 1 month, 6 months, or 12 months, however far back you want to go. There's ability to drill down into detail. You can see how often prescriptions are being refilled, or maybe not as frequently as they should be refilled. And so that is data that I think for a long time clinicians have been hungry for, and it gives us the opportunity now to make interventions and collaborate with healthcare professionals on another level than we ever were able to. So it's definitely beneficial.
Beneficial, yeah, no, because for those of us that came from the acute care sector, I always wondered how that interoperability between those various systems will work within your actual usability environment, within your workflow, as our previous speaker certainly spoke to. I'd like to bring over Dr. Alan Osfer now. I'm sure you're an EMR user, I assume?
Yes, I am.
How does Netcare work or not work, or currently what does Netcare mean to a practicing physician that has an EMR?
Well, I've been using it for 10 years. And I think the most important part of it is that It's the true patient-centric tool that we use as clinicians. I mean, we have an EMR. It's a very robust EMR that we've been using as well for 10 years. And an EMR is much more provider or organization-centric, whereas the EHR, or Health Information Exchange, or whatever we want to call it next year, is much more patient-centric. And so although I don't use it on every single patient every single day as a family physician or when I'm in the hospital dealing with patients in the hospital, I use it on most patients, and about a third of the time, a third of the patients that I see in a day, it makes a difference where I make a different decision clinically than where I would have made had I just had my EMR. And I think that's the most important piece with it, is it pulls in a broader sort of palette of information to allow you to make the kinds of decisions that would have prevented the things you went through in terms of that. And literally this morning I looked at it and I could tell which of my patients were going to hospital or an emerge or being seen at different outpatient facilities. I could track a critical result that had come through that was ordered by a different provider than myself and make sure that somebody was following up on it, those kinds of things. So it's made a big difference.
Yeah, so from an accessibility point of view, do you have to log in separately to your Netcare, or does your EMR trigger access to your?
You can do it either way. So you can go to a web page, and it's a portal type of view where you're viewing it, or if you're on your EMR, if I'm on a patient on the EMR and I want to see what's going on in the EHR, it's a click, a quick authentication, and I'm on that patient in the EHR. So we not quite single sign-on, it's dual sign-on, but it's in context, so you don't have to research the patient to find
There's not a major impact to your workflow,
That's
obviously.
right,
It's
yeah,
something
it's
that
very seamless.
You're willing to live with. Right on. And Dr. Muttitt, certainly from Chief Medical. Oh, that's Sarah to me. Right on. Oh, that's good. That's a nice reversal. Yeah, impressive. Give it up now. You're throwing me off. Oh, you want provocative? We'll have a racket up there now in a second. But seriously, Sarah, you're now the Chief Medical Information Officer with Alberta Health Services. That organization has gone through many changes over the last number of years, certainly from a structural point of view, governance point of view. Where does Netcare now currently sit in terms of the awareness and the acceptability of the higher level governance of Alberta Health Services as it currently stands?
So Alberta Health Services is basically the operator, if you like. So it's Netcare was an Alberta Health initiative, but we have the operational responsibility for Netcare. I think being a physician, I've been through you may all be familiar with the see one, do one, teach one. Well, I saw one when I was living in Alberta, and I think Trevor trained me on EHRs through the Netcare initiative. I then moved to Singapore and implemented a very similar stack and a very similar functionality, a couple of years newer and refreshed, if you like. And now I'm at the point where I'm back in Alberta, and it is absolutely foundational to our information exchange and the quality and safety of care that we deliver. But now we're pondering what the next steps are. So really, we're looking absolutely on a yearly basis. We need to prioritize the requirements for Netcare. There's lots of demand for access, and lots of demand for content. And we always we have so much money and so many resources and so much time. So we really have to look at where things are going to be most impactful, where we know we'll get high value, ease of use, and determine overall, which I think Alan would agree with, we really need to know our long-term direction. So many of you will know that Alberta's been going through a process over the last 6 months or so of really figuring out what our long-term IMIT strategy is as a province, working with not only Alberta Health and Alberta Health Services, but our colleges, pharmacy, everyone is participating, and our patients, which are a very big part of it. We've reached the conclusion, and our business case supports it, that Netcare will get us a long way. But there's some core functionality that as clinicians and patients that we can deliver better with more consolidated information systems. We still have far too many applications, far too many information systems. Integration is hard. Integration is expensive. How much do you do? We believe Netcare will always be with us because we'll never have a single solution that meets all our needs. But we also think that there's gaps, that we're going to have challenges, particularly things around secure communications, e-consults and so on with our patients, more advanced portal functionality. So we're looking at what that future architecture will look like, with more consolidation of our information systems, richer content to be sure, so lots of work to do on how clinicians are going to be entering data, making it easy for them to do the right things. Where does clinical decision support live? Does it live in the EMR? Does it live in a Netcare environment? So we have to make a lot of strategic decisions over the coming few months, actually, because we're in that process of finalizing the IMIT strategy. So it's actually an exciting time. We've had a great history, and now we've got, I think, a really interesting future ahead about how we mature Netcare further, but also take that giant leap to what we want our future architecture to look like.
Well, that's an unplanned segue into governance of this system, because certainly when you're dealing with a system that goes right across the broad spectrum of the healthcare system, let alone the population as a whole. How are those decisions being made in terms of what will it look like down the road, and who's involved, and are they truly meaningfully involved? I know there's probably all kinds of structures. I know we also want to make sure that we don't do things to people. We want to do things with people as a basic premise of change management and effective change management. I'll go down to the end of the table and just ask Karen, I mean, as a person who's using the system within the actual healthcare system day-to-day world, to what degree do you feel well, tell us how you're involved with governance right now as it relates to current and future planning, and does it meet the needs of, from your perspective and the people similar to you?
Yeah, pharmacy services in hospital as well as community through the college are involved in the governance and in the planning and the preparations with Netcare and the future of Netcare. And it's clinician focused. We sit around the table with prescribers and clinicians and folks from other colleges. So I think that's absolutely the right thing to do and the right place to be in terms of the decision making.
But you feel like you're getting your say?
We do. Pharmacists have advocated a lot for some of the changes that are in Netcare, I think from the very beginning, and we continue to do that. And it's quite easy to advocate. You can do it right when you're in there. If you see something that you isn't working for you or you think could work better, there's a button you can click and you can provide your feedback right there. And we have, it has circled back, and we've been around the table in terms of the making the decisions and making the changes. It doesn't always happen as quickly as we'd like it to, but it's definitely feel involved.
Nothing good comes quick. I've been told that. But moving along to Ryan, and certainly based on your experiences in the past, Ryan, I mean, you're now considered patient advisor. To what degree do you feel the current governance model is meeting the needs for people, not just like yourself with a chronic condition, but just in general as a population, having information available for eventually people, but certainly currently, so that people will have improved health care?
I find one thing that Netcare does is people go to their primary doctor and their doctor uses a computer. So they automatically think they have EMRs, electronic medical records. It's accessible by everybody. When reality, due to interoperability, it's not. But so there's that confusion. We need one system or systems that talk to each other so that no matter who you're going to, they have the record on file. In Alberta, we have a lot of resources, like it was said. This year alone, we got to participate in per capita funding for the first time, which gave us a lot of extra money, and I suggested that perhaps they take that money and devote it strictly to EMRs and building the system and getting everybody on board due to how important it is. You know, patient safety and quality is dependent upon that. It's also, I'll let you go first.
You're doing great.
Right. Well, certainly our big thing is making sure that we do have the people that are meaningfully involved. I mean, Ron, I assume that you feel like you're being listened to.
Oh, yeah.
Is that safe to say?
Yeah.
So you were not just a check mark on the box. Look, we've included these people, go away.
No, I've been very fortunate in the level of meetings that I attend that they actually do listen to me from the patient perspective and some of the business knowledge. Like I said, an ex-bank manager, I have a tough time believing, like, healthcare and business have never sort of been put together, and they need to be. You have banks in Canada that have records for millions of people for whatever they've done forever and ever. System capabilities are there. It's just going to take the buy-in from the top and everybody's colleges and everything to come on board to do that. It takes money. Apparently we have it. I understand Netcare is far along, but we really need much better. It's been worked on, you know, reality is I'd say healthcare has got to be at least 10 to 15 years behind what a business would be for computer systems and stuff. And it's really crucial to patient care, and that's what I advocate for. So.
Right on. No, that's interesting because not only are you taking it from a patient perspective, but you also bring your background as a bank manager. By the way, people will still like you. But that's another perspective, certainly, that would add to that whole governance value that you would bring to the table. Dr. Osford, I know certainly there's lots of issues around governing the EMR itself, I'm sure, within the province of Alberta. How do you feel the physician community is engaged from a governance point of view with helping determine the future direction or value of Netcare as it relates to the whole EMR environment?
Sure, and maybe I'll go back to the history a little bit in terms of how we first started and what we've learned, and it includes some of the patient issues as well. As, you know, when we put the RFP together and made the decision-making in 2003 to build this tool, we were terrified of what the public may think of it. Okay, we really were scared about what this was something that hadn't been done very much. I mean, remember, this is a while back. And so we actually met with community groups. There was a series of community groups that were regional around the city of Edmonton, because remember it was Capital Health at the time, to talk to them about it. And we were surprised to hear exactly what you said, that you mean you're not already doing it, was the first comment. And the second one was, well, duh, of course we think it's important, and why aren't you guys just moving forward with it? And even on the consent model, we had a consent-in model rather than a consent-out model at the time. Everybody said, well, you don't need a consent-in model, but the ministry felt comfortable with that as a starting point. And within 2 years, we went to a consent-out model because less than 0.5% of patients said no. So that's how we started with it. On the governance side, we formed a clinical working group, which was a group of clinicians, and we had a steering committee. And the interesting thing about the steering committee is all the key players in Alberta came together very nicely. So the College of Physicians and Surgeons, the Nursing Association.
Come on, tell the truth nicely, come on.
They came together very, very nice. CMPA was involved almost right from the beginning as well. We had all the different groups came together. They all recognized a need, and they all worked together with this thing at a steering committee level. There was no negativism at all about this. So at that governance level, it worked really well. At a clinical representative governance group, working group, it went very well as well, and we still have regular meetings. We got so successful that we had to go beyond just Netcare, and we now have an integrated clinical working group that oversees all IT with the Netcare working group reporting up to them.
That sounds like a very good solution for dealing with the whole interoperability of people on a broader scale, because all these systems can't be looked at if we talk about silos. You seem to have a model that would allow all things to be taken into consideration before directions are taken on the broader picture.
Yeah, everybody played nice in the sandbox, surprisingly.
Yeah, actually, and we'll be transporting Dr. Osford down to Newfoundland, Labrador.
And we weren't allowed to write prescriptions for
when
marijuana.
When we're finished with him, you can borrow him as well. Well, Sarah, I mean, it sounds to me, and I know that it's a very distinct difference between Alberta Health Services and Alberta Health when we talk about governance. Am I to assume that at the political and the higher level government level that there is the commitment to Netcare and that they are involved with some of the governance involved with Netcare?
Absolutely. The governance that Alan's referring to is actually Alberta Health governance in a sense. It is and Alberta Health funds and supports healthcare. So absolutely, it's a collaboration. I would say the relationship between Alberta Health and Alberta Health Services is better than it was, and I think trying to work collaboratively. We do have different. I think we have different roles, we have different responsibilities, and sorting those out and being quite clear on them is always an interesting conversation. But I think it has been a very productive relationship, and I can say that from the IT and the CMIO office, we want to continue that. I think the governance is getting more complex because the access is getting more complex. So as we sort of open up our Health Information Act and look at other users, I mean, this list that you have the slide up right now will be much, much larger over the next couple of years. And we're very, very focused on having that interdisciplinary team-based care, so everybody has to have access. And what kind of access and for what purpose? We also have very limited use of our data for secondary purposes. So opening up that opportunity for clinical research and so on is also really important. So governance has to evolve. We also find, and not surprisingly, that there's some duplication between the two organizations. So we're actually revisiting governance and looking at the structures within Alberta Health and within Alberta Health Services to be sure we're not duplicating or putting in more redundancy. And I think you'll see the shape of governance changing. And instead of having something that's termed, specifically like a clinical working group, we're actually going to start housing things under umbrellas. Our priorities are very clearly over the next 3 to 5 years around data analytics and use of data for system performance, quality, safety, and so on, consumer health, and that whole continuity of care. So there's 3 sort of areas where we want to focus. We want to put in relevant governance across both organizations that allows us to deliver that.
Actually, and I'll only ask Sarah this question, the fact that Netcare came out of a particular region in Alberta and grew into a provincial solution, did that provide huge challenges of acceptability to the other regions? Because I know we have the same situation in the Newfoundland and Labrador as well as other provinces, that sometimes people don't want to follow the leader.
No, it was really easy. You talked about hockey. Well, there's football. We're still into the football season. I think the reason you see things evolve the way they did, obviously it started as a capital health project, and Alan and I have had a good giggle because the strategy was that Netcare would help us bridge our ancient legacy systems, VAX and Tandem. Well, here we are 10 years later, and I'm still bridging. And so that's a bit of a challenge. Calgary was in a different position in the fact that they were rolling out clinical information systems. So they already had a more relevant solution, if you like, and they weren't as dependent on Netcare, and the rurals as well had Meditech across the rural zone. So everybody had systems, whereas Edmonton did not. So a real focus in capital to get that up and running. And then you can see incrementally that gradually people have come on. But it's also why we still have some inequality, if you like, across the province. So there's different things that are within Netcare for different regions. There's still more capital health or Edmonton zone content than there is in other regions. And there's still great gaps in content because we really don't have any primary care data. So I sort of smiling. Doctors always want more. They want to have more access. They want to have easier access. But there's the other side of the coin. If you want more, you got to give more. And so I'd say our next challenge is really about how we get more of that clinical content rather than just diagnostic reports and so on and dictated reports, and really get down to some of the day-to-day clinical content that will allow us to really manage patients more effectively.
Yeah, so essentially a good message is received well by all, typically. Looking towards the future, and certainly with lessons learned from the past, and I'll go down to the end of the table to Karen, what would you consider some of the, well, probably one of the biggest lessons learned that you have had with your experience of dealing with Netcare to date, and certainly on a go-forward basis, what would you see as being something that could be improved?
On a go-forward basis, and I'm envious of Glenn's success with MedRec, but as wonderful as Netcare is, we continue to struggle, I think, with the transitions in care. Which is very risky for patients. And so we have an ability to have great quality and safety and collaboration in the hospital, having Netcare and having that visibility. But the transition of the patient from hospital to home or to long-term care, continuing care, the hospital doesn't upload information into Netcare in terms of some of the detail that's happened to the patient while they're in the hospital. And the ability for pharmacists to talk to each other through Netcare, I think, is one thing that we're lacking. So we have recommended follow-up for community pharmacists and for the GPs, but getting that information across through Netcare is still quite difficult. And so I think on my wish list would be the MedRec. Just to improve the transitions in care and the quality there.
Right on, yeah, that's certainly something near and dear to most of us in the country is a seamless medication management strategy. And not just because of accreditation, but because it's the right thing to do, obviously, the patient safety issue. Ron, I ask you a question first. Are you involved with the personal health record project in Alberta?
No.
Okay, no, I just asked that generally before I asked just the overall question, so I guess I already got one of my
I believe
answers.
they have they're going to plan to have a patient portal available in the next month or two, where through Netcare, where patients would be able to sign on and see their medical history and what's on there. I'll go to my wish list for a second. That's one system for everybody, for all. I know it'll take a lot of work and a lot of money. It'll take stability at the top and commitment from the senior executives in Alberta Health Services. We've been subject to too much change at that level in different directions, so they need to do that. And I would just love it if somehow government could be separated from how Alberta Health Services operates, because too many times health ministers change or government change, and it changes everything in the dynamics of what was being done for the last 4 or 5 years, and now we start over again type thing. And so there has to be, you know, a clear direction of where and how it will operate and grow. And you need commitment from everybody, and it'll take a lot of work to get, like I said, all the stakeholders, all the colleges, all the different disciplines on board, but it's not impossible, and it can be done. So that's my wish.
It's quite a vision. By the way, I got to pick up on the comment, stability and leadership. Indeed. Absolutely. Actually, we used to make jokes about, geez, I hope the health system doesn't become politicized, and of course the health system is nothing but politicized. It's unfortunate because it does get in the way of actually getting good things done, particularly over terms of people's governance and governments. Dr. Osfer, from your perspective, now you've been at this for a while, and certainly you were one of the architects of the early days, and now that you're sort of, I won't say you're standing off to the sideline, because you're not, you're just now more of an active user probably from your personal practice. Where do you see some of the biggest lessons learned, and what can Alberta do to make Netcare even more valuable?
Well, I think there's sort of two parts to this. One is we continually mix up the function of an EMR with an EHR. And we need to be very, very careful we understand the differences between the two applications and how they work. And remember that an EMR can also be a CIS, so in the bigger picture of things. And so I think both tools are very, very important. I think it'll be very rare that we'll ever get to only one tool, because one is such a different tool than the other one. So they're both very important, and I think Netcare fulfills the EHR function very, very well. We have additional things that I'd love to see in it. So I'd love to see that we have direct secure messaging in it, which would solve a lot of the problems that you were talking about as well. That we have something called notifications, where we can actually fire off messages that are alerts. When your patient shows up in Emerge, you know they're in Emerge. All of that capability is there, we just have to turn it on. A patient portal is truly embedded and truly works seamlessly with the product would be hugely valuable. Making it more user-friendly in the mobile world in terms of tablets and in terms of phablets and cell phones would really help as well. In terms of everyday use, I mean, it's going up, and I just want to make sure people don't misunderestimate that slide that's in front of you. It's not that only 6% of residents are using the tool. In fact, well over 90% of our residents are using the tool. 6% of the total users are residents, because we don't have nearly as many residents as we have, say, in the nursing. We have way, way more nurses than we do physicians. So make sure when you're looking at those stats, that's not the percentage of people that are using it. That's the breakdown of the total users that are using it.
Yeah, and by the way, I don't even know how that slide got up there, because that's my left hand must have hit the button by mistake. But anyway, but yes, because I would assume that physicians, it would be a lot higher than 15% that are accessing electronic information tools.
It's well over 80.
Absolutely, yeah. So, Sarah, it always comes back to the leadership, and I know there's still that other political level that we can't always control or influence or inform to the extent we'd like to. But from Alberta Health Services' point of view, you know, your biggest lessons learned, particularly around the interoperability of processes and people, and where do you see, and don't be afraid to be your personal view as opposed to the official view of Alberta Health Services. But where do you see... I
could have sworn you said the tape was rolling. I could have sworn.
But where do you see this going?
Well, you know, I think I agree with everything that everybody at the table has said. We've got some very high priorities, things like medication reconciliation, that end-to-end medication management. We have so much good work going on in Alberta, but it's all in silos and pockets. So one of my biggest wishes is that we actually consolidate our processes. So it goes back, I think, a bit to maybe Catherine's question about process interoperability. We need to decide how we want our system to operate before we enable everything. We have architectural constraints, to be sure, but we have business process constraints. And I'm going to use e-referral as an example. We're building e-referral out of Netcare, and it's working right now really quite well for 2 arthroplasty divisions, so hip and knee, and 2 cancers, lung and breast. And one of the reasons it's working really well is that they have a central intake process. So that the referrals that are going through Netcare and being delivered, they're being delivered somewhere where somebody actions them. And it's a central point, and it gets distributed. For us to do e-referral provincially from every primary care physician to every subspecialist and on, with our current architecture with Netcare, is virtually impossible to do really, really well. So we really have to decide, how do we want to do referrals in Alberta over the next decade? Do we want everything to be, Alan refers to me because we're friends, or I refer to somebody else because we went to med school together? Or do we want to get serious about having a centralized intake process with good processes, understanding wait times, using our analytics to put people in the right place at the right time? So my wish is that as an organization, Alberta Health Services continues to work on improving our processes and the quality of the service delivery, the patient centricity of it, the good use of information to allow us to improve our performance, and then we'll automate it. But I don't want to go out and randomly decide we're going to add just yet another functionality for the sake of functionality. I want to be sure that it's actually aligning with the way we want service to be delivered and for the betterment of quality and safety and for our patients.
Folks, we do have a couple of minutes, but first for some questions from the floor, but certainly I would really like to thank the frankness and honesty of the people on the panel today, as well as the fact that they were able to give us an awful lot of the really useful history and some lessons learned and some future directions for all of us as we move forward on the electronic health record journey. So I thank you, folks.